an ICU backup. So what I do is that if I see that this patient has got some kind of bad cardiac history or history of stroke, something in which I might feel that he might need some ICU care. So at that time I take the patient to some other bigger hospital where ICU backup is there. Otherwise, if it's a smaller procedure, then I do it here, or even if it's a big major surgery, but the patient is healthy, there are no comorbidities, then also I do it here. Because at my place, I can do it at a much cheaper price compared to if I do the same surgery outside. So I just had a surgery in the morning. Although that patient has history of cardiac bypass, he has undergone coronary artery bypass surgery just 1 year ago. But after the surgery, what happened? Because the place from which that vein was taken, the leg from which the vein graft was taken, so that got infected. And so he was having a non-healing ulcer on the leg. So I had to do a skin grafting. But the patient's overall body profile was very good. We got all his workup done, his 2D echo and everything was good. And there was some issue with the budget also. So we did it here because the surgery also took hardly less than 1 hour. So it was like comfortable for the patient as well as for me to operate here. Now if the same patient, if his cardiac condition would have been kind of in a compromised state, or if the surgery would have been major, then I would have taken him to some other corporate hospital where I am attached. I am attached with several other hospitals in Ahmedabad. So regarding plastic surgery, see, unfortunately plastic surgery is a branch where many don't know that when to approach to a plastic surgeon. For example, if you have a patient, he has got some problem with the kidney or the urinary tract, you are sure you are going to refer him to a urologist, right? Your patient has had some cardiac problem. You know that you have to send him to a cardiologist or a cardiothoracic surgeon. Some bony problem, you will send him to an orthopedic surgeon. But when to approach a plastic surgeon, for what? So this is still an area where people actually don't know whom to refer. So there are so many things we as plastic surgeons do, but not many people know. So that's why they sometimes tend to go to the wrong place to get operated. But actually they should have come to us. So what are the things we do? It is just a small demo. So basically what is plastic? Plastic means to mold. So we borrow the tissue from somewhere else. It is called labioplasty. If it is the nose, it is called rhinoplasty. If it is the breast, it is called mammoplasty. If it is the tummy or the abdomen, it is called abdominoplasty. So this plasty word means to change the shape. In plastic surgery, there are so many branches from head to toe. So what are the things I do? It's mainly the head and neck cancers. The cancers of the head and neck, I don't remove the cancer. The cancer is removed by the cancer surgeon. But once the cancer is removed, so there is a deep defect. And that defect has to be covered by the plastic surgeon. So there are different ways to cover that defect. Then there are this trauma. Trauma can be of the face, wherein it is not just the soft tissue but even the bones of the face. So if there is a fracture of the mandible, the jaw, the maxilla, the nose, so it is a plastic surgeon's job to treat that. Augmentation, reduction, there are so many surgeries that we do as cosmetic surgeons.
डिटेल में समझा कॉस्मेटिक सर्जरीज डिटेल में समझा
डिटेल में
यहाँ कई वस्तु કરી શકીએ यानी कि
Sure. So starting with a basic plastic surgery which I had done today early in the morning. So basically, see, the skin has several layers. There are 7 layers of the skin, right? So if sometimes there's an accident, or sometimes the person can get burnt. So there are wounds. So those wounds have to be covered, right? So this is a post-burn wound. Now this had to be grafted. So skin grafting was done. Okay, so, for example, this wound again.
Can this be done in old injury as well?
Yeah.
If old burns or old injury having the skin defect, it can be resolved.
So now you see, so this kind of wound is like a two-dimensional wound. There is a length, there is a width. It is not depth. It is not a very deep wound. It is mostly a two-dimensional wound, right? So there we do skin grafting. Here you can see there is no exposed bone or tendon, and the wound is on the surface, almost at level with the surrounding skin. So there we do skin grafting. This is the skin grafting handle, and this is skin grafting blade. This is the skin, which what it looks like after harvesting from the thigh. 99% of the times we harvest the skin graft from the thigh. Right? Now there is another condition, another surgery. It's called full thickness skin graft. So in full thickness skin graft, what we do is that, like, for face or for hands, for these palm defects, this split thickness skin graft sometimes is too thin. So you have to match the texture also of the surrounding skin. At that time, so for the face, ideally we should take graft somewhere around the head and neck region. So either it is like in the supraclavicular region, above the collarbone, or sometimes from the back of the ear. If you take from the back of the ear, the scar is concealed. It is never seen. So in split thickness skin graft, the thigh from which you are taking the skin new skin automatically comes after 15-20 days. It heals on its own. You don't have to do anything for that. But when you are doing a full thickness skin graft, you have to stitch this part from where you are taking the skin. Right? So this was the scar. This was patient had come with a bad scar, and so we removed that scar, created a defect again, and then put a full thickness graft. So the scar has improved. Then flaps. So skin graft is like, it is completely separated from that part and then placed on the other part. But flaps they are in continuation. Flap carries with it its own blood supply. The skin graft will take a new blood supply, but the flap, it will carry with it its own blood supply. Right? So flaps can be different staged. For example, this patient had a cancer of the knee joint. Again I said, I am not operating the cancer. The cancer is removed by the cancer surgeon. I operate the skin cancers. There are certain types of skin cancers which happen when a patient is exposed to sun for a very long time, especially in white patients or in patients who have got very fair skin. So when they get exposed to sun for a very long period of, for many years together, they can develop tendency to develop skin cancers. So I operate on those skin cancers, but this kind of soft tissue like sarcomas or bony cancers, this is operated by the cancer surgeons. So once the cancer surgeon removes this cancer, so then it is my job to cover this. So again, I have taken the skin from the thigh, but it is a thick skin. It is not that thin skin. I showed you how that skin looked like, right, after harvest. But as you can see, this is a very thick skin. This is the skin and fat and fascia. So this is completely rotated and covered to close this defect. Now from where I have taken this thick skin, there also a defect develops. Right? So that defect is then covered by skin graft. See, I'll give you an example. I had, say, $10,000 with me in my wallet, and my wallet got robbed. So I have got nothing with me right now. Okay, but I have to live, I have to eat. Or how will I? With $0 in my hand. Now you have $10,000. He has also $10,000. Right? So then I will tell both of you that I need some money. So what will you do? You will give me $2,000. Or you gave me $5,000. You can live with $5,000. I can live with $5,000. But you thought that I need some more because I originally had $10,000. I was not robbed. So what will Dr. Siddharth do? He will give his $2,500 to you. So if I tell you what happened, I have $5,000, you have $7,500, he has $7,500. All are in a better place. Rather than somebody becoming absolute zero you have sacrificed something of yours in order to save me. It is like that. So when that knee area had nothing with it, so we have taken the thick skin from the thigh, but now because the thigh has given a considerable portion of its area to that knee, now this also needs some help. So this thin skin graft is now taken from another thigh. Okay, and that's the surface layer, yeah. And their new skin will automatically come from where we have taken this skin graft. So everybody is now balanced. The knee is also balanced, the right thigh and the left are also balanced now. Again, so this is an example of a pedicle flap. So this patient, she had a skin, this is the skin cancer I was talking about. Okay. So this skin cancer, I operate. I don't need any cancer surgeon for that.
That's it.
So this is removed and this forehead skin is like rotated to the defect. And initially, because patient was not able to close the eye because there is a lot of tension. You close it with a lot of tension. So I had to do tarsography. I had to stitch both the lids. After a few days, this thing gets settled and the patient is able to close and open the eyes. So this is how she looked after a few days. Her eye opening is very good, eye closure is very good. Only thing is, yes, there is no eyebrow. But because the cancer was on the eyebrow,
Okay.
so you have to remove that. So that has to be sacrificed, right? Whenever there is cancer, you have to be very radical. Otherwise, it will come back again. So sometimes there is a multi-staged flap. So for example, this is the leg. You can see the bone is exposed, and this bone is not good. It's a totally dead bone. So osteomyelitis. But now this leg is very much scarred. This patient had met with an accident. So this entire skin is very scarred. I cannot use this skin to cover the defect. So at that time, what we do is that we take the skin from the opposite leg. Again the thick skin. And then both the legs are fused with each other. Like this. So this is the skin of the right leg from the calf region. And this is now attached with the left leg.
This one.
This one, yeah.
Then you this.
Yeah. So this is leg, but when it suppose if this is forearm, so then what we do is that we take the skin from the abdomen like this. You cut it from three sides. The fourth side is remain intact because the blood supply will come from here. So 3 cuts, 1, 2, 3. The blood supply will come from here. It gets opened like this. You fix your forearm like this.
Okay.
So this is done for 3 weeks.
Still
3 weeks, it will remain like this. These legs are fused to each other for 3 weeks. After 3 weeks, you do another surgery and then separate it. So
blood vessels will be already developed.
yes, perfect. So this is the time that takes for the new blood vessels to develop. So now after 3 weeks, what happens is that this skin flap will take new blood supply from here, superior, inferior, lateral, and from the base on which you have placed the flap. So after 3 weeks, you can just cut it, remove all these rods, this external fixators, and this skin now becomes a part of the left leg. And now because we have taken a thick skin from the leg, so this also needs to be covered. So that is covered with the skin graft. This was the skin graft. Right. So this is how it looks. See, now the skin of the right leg is now a part of the left leg. So it is that was such a big skin, but sometimes even for small skin, for example, a finger, when a bone is exposed, so you cannot just put a skin graft. Skin graft cannot be placed where the bones and tendons are exposed, or if it is a very deeper defect. As I said, it's a 3-dimensional defect with depth, you need a flap. If it's a 2-dimensional defect with only a length and the width, then you need a skin graft. So in this case, skin from the ring finger is taken and fixed with the little finger for 3 weeks again. And after 3 weeks, this is divided. Again, as I said, since we have taken a thick skin from here, there will be a defect here, so we have to cover it with a skin graft. So normally in such cases, we take the skin graft from the inner arm. That is patient's choice. If patient wants to take the skin from the thigh, we take it from the thigh. Otherwise, we tell them, because it's only one anesthesia in the arms, in the entire upper limb. So we can take the skin graft from the arm. Right? So, and then there is something called free flaps. As I said, flaps carry with them its own blood supply. But it is not 100% times true. So these are the free flaps. Now what happens is that this is the cancer. So those who smoke a lot or those who chew tobacco, so they can develop this kind of cancer. This is the oral cavity cancer. So the cancer surgeon will remove the cancer, and then there is a defect. Now I can take some skin from the face also, rotate it here, but then the face will be disfigured. If I give cut here, how bad the patient will look, right? So in such situations, we do something which is called free flap. So the skin of the forearm is taken and along with its blood vessels. So these are the blood vessels, the arteries and the veins. And from where we took this thick skin, there we have to put the skin graft. Okay, and these blood vessels are then connected with the blood vessels in the neck. So this is the surgery which I do most often in my practice.
It's very, very difficult and very precise.
Just was James blood vessel, then you.
So the blood vessel is connected in with the blood vessels in the neck. So what happens? The blood flow starts flowing in this skin, right? Because thicker skin will need some kind of blood.
Yes.
So it has to. So either it takes its own blood supply, the way I showed you, but here it was not possible because otherwise you have to give a big cut. So that's why you have taken the skin from the distant part of the body and along with its blood vessels. So the skin fills the defect and the blood vessels is connected to the blood vessels of the neck, and so the flow starts going into that skin. So this is how the patient looks after a few weeks of surgery. Actually, if you were to come in the morning, I would have shown you 2 patients who had come for follow-up after this kind of surgery. So sometimes you take skin from the forearm depending on the size and depth of the defect. For example, this patient, I had taken the skin from the thigh. This is the thigh. And this was a very, very huge defect, right? And very deep one. So from the thigh, this skin was taken, and this is that skin. So initially, of course, it looks swollen, but gradually it settles with time. Now, we'll come to cosmetic surgeries. So this is breast augmentation. Breast augmentation using silicone implant. As you can see, there is so much improvement in the shape of the breast, right? So that of course depends on the patient's body profile, how tall she is, how thin or fat she is, and what is her profession. Those who are in modeling, they want very much like enhanced breasts, so we have to use larger volume implant. For example, this woman was a housewife, so she was not interested in very large implant. She just wanted to improve the shape of her breast. These are the implants. This is the silicone implant. Okay. Then rhinoplasty. You can see this girl's nose was completely depressed on one side. So and also there was little bending of the nose also. It was slightly deviated. So that has been corrected. You can see this. Look at the side profile of this girl before surgery and after surgery. So even the face has projected down. Previously it looked like, you know, as if it was flat. So it is called a dish face appearance. And then this is the breast reduction when the patients have got very large breasts. So we can also do reduction surgery. That helps a lot in reducing the pain, the weight of the shoulders. It's a very relieving surgery for the patient. You can see this is liposuction. This is a double patient with double chin, and it's a very simple procedure, like a 15-20 minutes procedure. This chin has become flat, and this is just taken 2 days after the surgery. So then there are patients who have enhanced chest due to excess fat deposits. That's called man boobs. So we also do surgeries to reduce that. You cannot even see a scar, but actually these are very two small points from which the fat was removed, and even a cut was given just at the lower end of the nipple, but it gets concealed and you are not able to see the scar.
Men with big. Right.
Yes.
And then this is tummy tuck. Females, after pregnancy, their tummies become very lax. So even after doing a lot of aerobics or exercises, yoga and everything, they are not able to reduce that skin. They can reduce the weight, they can reduce fat, but that extra skin that fails to go. So you have to tailor that extra skin and tuck it. That's called tummy tuck. So look at this side view and look at this after the surgery. Then scar revision. See, for example, she came with a very broad scar. Patients sometimes feel that it's a scar removal surgery. There's nothing called scar removal. It is always a scar improving surgery. Once a scar, always a scar. If that skin which is given by God, if it gets torn, gets cut, gets burnt, scar will always be there. But it is in our hands to make it as little perceptible as possible. This was one of my favorite patients. She is from Tanzania. I would say she was from, because I operated her 3-4 years back. I didn't know her. This pic was there in this presentation. I didn't know. I was going to show you from my stored photographs. So this girl, she was a very, very nice lady. She was. Very unfortunately, in Tanzania, she met with an accident, and you can see the scar which is there. It is so horrible, right? Plus, you can see these dots. These dots. So when you take stitches, you pass the needle. The more away from the wound you pass the needle, the bigger or broader it will look in future. First of all, this wound she must have had at the time of accident was taken by very thick threads with a very large needle. That is what I assume.
Yes.
Because I can see the thickness of these dots.
Those are needles.
So those are the thick needles. Only a thick needle would give like impression of these thick dots, right? So there was a contracture here. The patient was unable to smile, and she always had that kind of feeling as if somebody is pulling her skin. It's a stretching sensation. So in this thing, see, as I said, once a scar, always a scar. There is no way I can make this disappear. I cannot do any magic. So there is a surgery. It is called Z-plasty. I will show you the details of this particular patient. So after the surgery, as you can see, scar is there, but it's a broken scar. Instead of a straight single line scar, it is broken now. So it gives less prominence, as well as that tightening sensation is gone. Patient can smile properly, can talk properly, and she gets rid of that pulling sensation.
This procedure takes
It all depends on the length of the scar. For example, in this case, it took me very long. It took me 2 hours. 2 hours for this thing, because it is so long from this angle of mouth to here. So, and most of the time, I think this was the longest I have done, a longest scar revision. Usually patients come with this much length or this much length. So that takes like around 45 minutes or 1 hour maximum.
because so many people in Tanzania have
This kind of scars.
Yes.
Okay.
So you see, he has already heard the patient.
Yes.
He done treatment.
Then moles, sometimes patients, their moles tend to become bigger. So we do mole excision surgery. This patient came to me. See, this is not an immediate post-operative picture. I had just forgotten about this patient, and then she called me after 4 years. The doctor, you had removed a mole from my nose. Now I want to get rid of mole from my chin. So when she came for this nose surgery, for the chin surgery, I took her photo after 4 years. You can see, you cannot see any kind of mole now. Here also. And see, plastic surgery is so huge. So many other faculties, they need our help. For example, extra fingers. What happens? Patients go to orthopedic surgeons. But orthopedic surgeon will call us. That is a very simple thing. If something which can be done here, if it is done elsewhere, it will be more expensive. Right? Then there is a condition called pilonidal sinus. I don't know if you heard about this. I don't know how common this is in Africa. In India, we have patients who are very hairy, and there is a very big percentage of such patients who are very hairy. So those who have got a lot of hair around their lower back, when they sit for a very long period of time, what happens is that chronically those hair shafts, they start puncturing their own skin, and they go inside and they form this kind of sinus. So this sinus, this guy was previously operated somewhere else, but it got recurred again. So whenever there is a sinus is a blind pouch. So like you can see an opening from here, and when you put a probe inside, so there will be an end. It will hit that end. So in this tunnel or this cavity, I would say, there is a lot of infection. There's pus discharge. There's a lot of foul smell. So the job is to remove this entire sinus from its base. If you keep this base intact, then it will always recur. For example, this is the patient's back, right? And this is an opening which you can see. This the opening of the sinus. You can see from outside. You will see, oh, it is just hardly 5 mm opening. Why is the doctor telling me to do such a big surgery? That is because, although from outside it looks 5 mm, but the depth, if you see it in a scan, in MRI scan, you will realize that this is the opening, but it has got multiple tracts like this going at so many places. These tracts can be 3 cm long or like 2 cm deep. So the thing is to remove this thing in toto, like this. If you do not remove, if I remove it like this, if I transect these tracts, some cells of the tract will get trapped inside, and they will form the sinus again. That will be recurrence. So this is removed from its root and covered with a flap. Again, so this is the flap, which I explained you, thick skin. Now this is carrying its own blood supply. Its blood supply is coming from here. So there is no problem, right? But in the graft and in the free flap, the microvascular surgery I was explaining to you, in that it has to take its blood supply on its own. So in the free flap, you have to connect the vessels. In the graft, you just put it at the place where you want it. Now because this defect is very deep, you cannot put a skin graft. As I say, if it's a 3-dimensional defect, you need a flap. So this is another patient. As you can see, there are 2 sinuses, 1 and 2. This we put an infant feeding tube. From one end, it was going and coming out of the other end. This patient is after once the wound was healed. Right. Then bed sores. I have treated many patients of Kenya with bed sores. Not the original African patients, but the Indian patients settled down in Kenya. I have done at least 3 to 4 such cases. So this lady, she was, of course, she was from Ahmedabad only. So she had this big bed sore, and then again this is covered with a flap. As you can see the depth, this is so thick, right? This is so deep. So the skin is given cut and rotated to cover the defect. And this was one of my most successful surgeries. You can see there is a totally separated limb. This was replanted. This patient's newspaper cutting is also kept
But
outside.
it requires immediate action.
Of course, yeah.
It's amazing.
So if you book a flight for him, he can travel down and immediately do it.
And then sometimes ear deformity, when this is called prominent ear. The ear can get sometimes they are like this in some patients.
Yeah.
So this is the surgery to like push the ear back to its original position.
Plastic surgery does so many things.
Now this patient he had a very strange kind of injury. Only the skin, this upper skin of the part of the ear was gone. So this is the entire cartilage which was exposed. As I said, you cannot do a simple skin graft on an exposed bone, exposed tendon, exposed cartilage. So skin from the back of the ear was taken. It was a 2-staged surgery, but after 2 stages, it looked like this. And swelling. So this guy is my neighbor. He is just 1 floor below mine in the same apartment. So he had this big swelling, and this is after surgery. You cannot see any scar. Now where is the scar?
You can't even say that as
So this is an impression. Many people think that it's a plastic surgery, there should not be any scar. Of course there will be scar. If I am giving a cut and I am taking stitches, there will be a scar. But here the scar is concealed in the hairline. Now, maybe if this patient would have gone to a general surgeon, a routine surgeon, he would have probably given a cut here.
Yeah.
Yes.
So that would have been definitely prominent and visible. But what we do is that we give the scar, we try to conceal the scar. The breast augmentation patient I showed you, so the scar is hidden in the breast crease, inframammary crease, so it is not visible. But there will be.
Bikini और बनाया है liposuction में. Bikini line ऊपर भी.
So ये जो tummy tuck नु बता दी तो the tummy tuck photograph I showed you. So that is also the scar is given in such a way that the patient wears undergarment, so it has to be concealed in the lower undergarment. Right. So basically, it's a problem-solving branch, and there are, plastic surgery is endless. It's endless, and almost everyone needs our help. A neurosurgeon, he has done a neurosurgery, right? So now, if there is a skin defect, so he calls us. If there is an orthopedic surgeon with a crushed bone fracture, but with a skin loss, there our role comes. After a bypass surgery, for example, this patient who is admitted, the graft was taken from the leg, the vein graft, but it got infected. So our role was there. Sometimes the sternal wound, the bypass after coronary bypass surgery, the sternal wound opens up. So at that time our role comes to cover it. There are sometimes females who have